Hmm. Um, We will be starting in about 3 to 5 minutes. And if everybody can hear me, can bring a thumbs up if they can hear me. Mhm. All right, great. Thank you so much. If you want to, we will answer questions at the end. So please put questions in the Q&A section or the chat section. Okay. All right, all right. Waiting for my colleagues to get here. Um, Let me get them brought in here. All right, all right. Waiting for my colleagues to get here to start. Give me a couple minutes here. If you guys have any questions, please put them in the chat box. As I mentioned shortly, I'm Dr. Ronald Torrance, and I'm here to give a quick update on how to relieve knee pain webinar. I'm gonna ping these guys now and make sure that they're on their way. Just want to make sure everybody can hear me. I think Henry on here said that we had the guys could hear me. So Mm. Thank you, Henry. All right. I don't want to keep everybody else waiting. I ping my colleagues. I'm gonna get everything going. Hopefully they'll be here for the question and answer at the end. Making sure Dr. Lieber's not waiting. So I'm hoping that everybody can join at the end. I apologize about this, but I'm Dr. Torrance, and you got me for right now, and I think that's plenty. So we're here to talk about how we can relieve knee pain in a webinar and explain to you what options are out there and what's being currently done and what really is the best solution. So something that's big on my agenda and everybody else's agenda is getting people to move away from steroid use. And everybody can see my screen, correct? If you can, please raise your hand, just make sure. And this is a study that looked at randomized control trial of triamcinolone, also called Kenalog, and what it actually did for knee pain. And the use of interarticular triamcinolone compared to interarticular saline resulted in greater cartilage loss. So steroids cause a decrease in cartilage, which can really speed up breakdown and or pushing people towards a knee replacement. And it's not just one study, it's also another study that here looked at the same thing, a multi-center longitudinal study that looked at steroid injections and why they actually lead towards knee replacement. So this is a really nice infographic showing what happens if you have a steroid injection. It goes into the joint, and it's not just going in there and calming down inflammation. It's actually killing chondrocytes, aka cartilage cells. And those cartilage cells are what are responsible for making new cartilage. So if we're decreasing the cartilage cells, you're decreasing the cartilage in the knee joint, hence making knee replacement happen faster. And this was the database study, and there's over 3,800 patients in this study, and they were followed up over 9 years. A very, very large, robust study that showed that cortisone or steroid injections are not without risk. And again, just showing you here, no steroid injection, only 5% of people went on to a knee replacement. And with steroid injection, a third of the patients, so 1 out of 3. And then here, the other side was, only 1 out of 20 would go on without a steroid injection. So what about meniscus tears? Is this something that is analogous, or just something that really is something for knee arthritis? Well, there's been multiple studies now that show that if there are any kind of arthritic changes, even mild, that doing a meniscectomy actually exacerbates or makes knee replacement more likely as well. So again, we have multiple studies here, and this is the arthroscopic surgery study that was done in actually really big medicine journal, not JAMA. It's in I'm drawing a blank right now. Was it in JAMA? It was in anyways, it'll come to me in a second. But this is an original article, arthroscopic partial meniscectomy, where they went in and clipped out part of the meniscus, and then they went in and did nothing. And what was found was that in the trial without knee arthritis, but with symptoms of degenerative meniscus tear, the arthroscopic meniscectomy is no better than those of a sham procedure. So going in and doing a sham procedure versus clipping out the meniscus, there was no benefit 1 year out. So doing a surgery on a meniscus tear versus not doing a surgery on a meniscus tear has no benefit, and it also actually makes things worse. And this was also another surgical degenerative knee during the scope. Taken together, these findings do not support the practice of scoping people for middle-aged or older patients with knee pain without signs of clicking or locking. So, but Dr. Torrance, all these surgeries, I mean, these surgeries work really well, right? And they don't make things worse, but are we actually doing anything to help? And okay, knee replacement works really well. If that's the thing you have in your head, let's do a knee replacement. Well, here's the risk for knee replacement: infection about 1%, blood clots, continued pain in 20 to 37% of patients, heart attack, allergies and medications, revision surgeries. There are a lot of risks to surgeries, and if we can avoid that, we should. So what is regenerative medicine? What does it do? And it's the process of really using your body's own cells to excite and cause a change in the body where an area that's not getting better, and to establish normal function. And I like to give the analogy: if somebody's phone's not working, you turn it off, turn it back on. That's a hard reset of that phone, and that reset for that phone usually makes the phone work again. In joints and knees, this is what I compare platelet rich plasma injections versus bone marrow concentrate injections to reset that healing process in the knee and hopefully reestablish normal function. And we're focusing on the tendons, the ligaments, muscles, joints, meniscus, cartilage, and nerves. Now, don't get me wrong. In ligaments, we've seen repair in all these injections and MRIs and post-MRI follow-ups. We've seen some cartilage and some fibrocartilage regrowth, but I don't tell patients that. I promise them really functional outcomes. And what does PRP do? What is platelet-rich plasma? What is it? Well, here's a study that looked at how platelet-rich plasma, very similar to that corticosteroid injection study that we looked at, how that actually prolongs and lengthens the risk for knee replacement. So that's one of the things here. And I'm just making sure I'm not missing my colleagues. Give me 1 second. Unfortunately, I feel like they got hung up. So I'm going to keep talking about this. So what does PRP do? This is Mikel Sanchez. He's out of Spain. Him and his compadres and partners have really shown that by doing PRP, you can prolong and protect. It's cartilage protective. Here's and this was that study, and this is showing you really, it was a retrospective study looking at patients from 2014 to 2019, 667 patients. 85% of the patients who had PRP achieved delay in total knee arthroplasty for 5 years of the study. So delaying the need for knee replacement, lower level OA, more PRP injections, younger age, this all helped and delay knee replacements. Again, I see some people coming on. I want to make sure I'm not missing my colleagues. So what else can we do for delaying knee replacement? And this is really where the rubber hits the road. And we've seen very, very good, robust studies by Dr. Philly Pernigow, who's mentioned here. That's my colleague, Dr. Pappas. That's called an interosseous injection here. And this was a randomized controlled trial that looked at injecting into the bone for knee arthritis. And what was unique about this study was that they looked at injecting the bone only, inside the bone, or also in the joint only. And most typical traditional orthopedics at this time are only injecting in the joint. They're not actually injecting into the bone. And that's thinking very, very inside the box and not outside the box on how the knee actually functions. The knee is an organ, and it has bone structures, it has ligament structures, it has tendon structures. And if we're going to get the whole knee as an organ healthy and strong together, we need to think in that outside the box thinking and inject not only the joint, but also inject the bone, which makes the cartilage and can make the whole joint healthier and stronger. Okay. And this is what that study looked at. It found that only 1 out of 5 patients went onto a knee replacement when they injected the bone, and they didn't even inject in the joint. And this was from 2000 to 2005. And those patients were followed up in 2020. So 15 years only 4 out of 5 patients avoided knee replacement, only one needed a knee replacement. And this is the interosseous lesion. This is what we see in a lot of these patients with knee arthritis. And this might be you. This might be your friend. This might be your loved one. And this is really where we inject into this area to help that bone get stronger and healthier, and then hopefully help you prolong and prevent a knee replacement. So after treatment with MSCs, injection of the subchondral bone, regression, and this is what it looks like if you do a follow-up MRI later on. So I'll take questions. I'll field questions. I'm trying to get my colleagues on here. I apologize. We take lunches, but sometimes they get missed. And if you want to pop some questions in the Q&A or the chat box, please let me know. If you want to follow us or schedule an appointment, give us a call down here. We see patients in Sarasota, Tampa, St. Pete, Orlando, and we do telehealth consults throughout the state, throughout the country, to be honest with you. We like to think that we're doing this the best of our ability and helping our patients get back to doing what they love through non-surgical orthopedics. And this is the knee study, and I'm here to field any questions you might have about what we do. So questions. Can hip PRP and stem cell procedure impact the meniscus? So that's a complex chain of how the body moves and works. If we're working with the hip, if the hip's having problems and the hip is symptomatic, we're trying to make the hip stronger, healthier. There is a very good study that looks at, I'm going to answer this live for you, Randa. When we treat the hip, if you're getting medial-sided knee pain and you're weak in the glute medius or glute maximus, there is a study that looks at and says that medial-sided knee pain is likely weak glutes and weak hamstrings, but that's really where I would say that it can impact that, and there could be something that goes on there. If you're a patient of mine or a patient of somebody else's, come in and see us. We'll be happy to discuss it. Can PRP still help bone on bone? Great question. So what are your symptoms? Is it bone on bone? What images do you have? There's a lot of questions that I have to follow up to that. Is it really bone on bone? Is it grade 1, grade 2, grade 3, grade 4? PRP can help. And there are some situations where doing PRP just into the joint will help that person with bone on bone. So I would come in for an evaluation, work with one of our clinicians, one of our board certified clinicians. They're fantastic. They'll give you an hour-long eval. That's what our evals look like to help determine the root cause of your issues. All right. How long do the stem cell injections last before you need another treatment? So anonymous attendee. So I just went through that in the lecture. So Philippe Pernegal looked at bone marrow concentrate into the bone. And so that's a stem cell procedure. Bone marrow concentrate, where you get your body's stem cells from. And injecting into the bone, Philippe Pernegal found that only 1 out of 5 patients needed to progress to a knee replacement. So 4 out of 5 patients in that study were able to avoid a knee replacement 15 years later. So that's the best long-term data we've got. Hopefully 15 years, hopefully longer, but that would be the best answer that I have. Which one do you recommend for knee joint with potential lowest risk of complications and fastest recovery? Great question. We do a comprehensive workup, history, physical, talking to the patient, understanding what their issues are, how much pain they're in. All those types of things factor in our decision to help get you back with the lowest risk of complications and the fastest recovery. So it's going to be a multifactorial workup to figure out what things you're trying to get to and how fast you need to get back, whether it's some sort of trip that you want to take and you want to be more functional. There are some things I can do to help make you better temporarily for those times frames. And absolutely, I think that would be probably something to have a further conversation with one of our clinicians to determine what you're trying to get back to. Are the procedures covered by insurance? How many injections are necessary? So great question. So our evaluations, we take most major medical for our evaluations. And unfortunately, at this time, we do not take insurance for those procedures. Now, that being said, we do have, so that actually it's yes and no. We do take insurance. We do take Regenexx corporate insurance, which is over 1,800 self-funded insured companies. Manatee County Schools is one of our largest companies. City of Port St. Lucie, 7-Eleven. We also have Under Armour. These are all groups that cover our procedures because they see the benefit for their employees. This is called a corporate benefit plan, and it's a self-funded insured company. So yes, how many injections are needed? We try to do the best we can with one series of injections all in the same day or in a series with the bone marrow procedures. So hopefully that answers your question. If you have any follow-up questions, please follow up. Is age a factor as far as recovery time? Absolutely. So all patients, when we are younger, we respond quicker to things. When we are older, we typically take a little bit longer to respond to things. So yes, is age a factor in recovery time? I say yes. Everybody's different. Everybody recovers differently. And that would be the answer to that. How much is the evaluation? Again, most of our evaluations are covered by insurance. If you're out of network with us, we typically do our evaluations for $325. So that would be the answer to that question. If we don't take your insurance, we would be a cash rate. How long does it take after a stem cell injection PRP in the knee to see the results? Another great question. So typically I have my patients come back to see me at 8 weeks, and I expect them to have some improvement at that point. I don't expect you to have your maximal improvement. As I talked about and alluded to in our presentation there, we do see that really 3 to 4 months is where we see maximal improvement, and that's where people plateau and typically hopefully stay there. So that would be that. So usually 3 to 4 months is when I typically see the biggest results and hopefully plateaued results. Done. Is general anesthesia used for bone marrow procedure? So I've done, at this point, thousands of these procedures. I've had to use local on a select few, probably a handful that I can count on, and those are people who have elected to use that. So it is not needed for general anesthesia is not needed if you're using the proper tools like we do with our numbing medications. Ropivacaine, simply our anesthetic of choice. And then we're also going to use ultrasound guidance and give you a couple of medications to make you comfortable. So typically, general anesthesia is not needed would be the answer. Do patients need more than one series of treatment? Everybody's different, and we try to get our patients to have the best benefit with one series of treatments. It's usually one day, and you come in, you do either a blood draw or bone marrow aspiration, do the re-injection. Now, we do have a Regenix protocol where it's a Monday, Wednesday, Friday, or Tuesday, Thursday, Tuesday, but that would be a series that everything's clumped in and looped together. So yes, sometimes people do need other procedures, but that's based on the patient and the patient how they're doing. And we're really trying to make sure that we get you there with the first procedure that we do for you. Any other questions? Sorry, my colleagues, they got hung up. They were supposed to be here today. They have us on their schedule, but sometimes patients need us and we cannot make it. So I appreciate everyone's time. If you have any questions, we do have, hold on, let me see a couple more Q&As here real quick. Let me see here. Do you bring your x-rays in? Answer live, yes. When you call our call center, or education center, as we like to call it, usually speak to Erica, Sonia, or Natalie. And they will gather all the information and things we need to do a very thorough consultation. Again, the consultation is an hour long. We take our time with our patients. We do a diagnostic ultrasound if it's pertaining to the knee, and we're going to make sure that we figure out exactly where the pain's coming from. So total cost of procedure, assuming no coverage. So for knees, since this is our knee pain issue, for platelet rich plasma, it's usually $1,500 to $2,500, depending on a couple different things, whether we're doing a bone augmentation or not for your platelet rich plasma. For bone marrow, we're usually between $6,000 and $9,000, assuming no coverage. Does age matter in the quality of bone marrow? Amelia, that's a great question. And again, that's going to be multifactorial depending on the health of the patient. That also, there's a lot of different things that affect the quality of the bone marrow. Age is one of those. that we that we will address in our consultation. So absolutely, age does matter. Is it the most important factor? I wouldn't say after a certain time frame, yes, it becomes a very important factor, but I don't think it's the end all be all for issues for bone marrow, which is where your stem cells come from. Other questions? Going once, going twice. What is the waiting time after first visit to get procedure done? I heard for plasma has to be sent from California. No, 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 no. That's all this stuff is coming from your own body, and we will do this. You will be once our consultation happens, our team will work with you on dates that work best for you, that we would do a blood draw and a re-injection of your platelets, if it's platelet rich plasma that we recommend, or if it's bone marrow, from the bone marrow from your body. So that's not true. I had heard for plasma has to be sent from California. That is not true whatsoever. No, that's not true. I just told you that it's not 9 months. We do those in the same day. What are the precautions we have to take after the stem cell procedure and a PRP? Again, precautions are anything like post-procedurally. We're gonna give you a lot of directions and guides on how to have the best outcomes. We're gonna work with physical therapists typically after our procedure to make sure that we get the best outcomes. And then we're going to see you back for follow-up and make sure if any adjustments need to be made, we make those. Flavia, major medical, Medicare is, and I'm gonna quote Dr. Pappas from this, is like a large ship. Changing any direction takes time, and we are not sure when insurances will start covering. That's the most PC answer I can give you. The evidence is there. The evidence is sound that PRP and bone marrow concentrate do fantastic work for arthritis, for tissue tendon issues, partial tissue tendon issues. But unfortunately, insurance coverage does not mean that does not happen instantaneously after the evidence being there. Grace, great question. How long does the platelet plasma treatment last? We're going to give you a playbook on making sure that if it's a degenerative issue, there might need to be follow-up procedures later on in the future, but we're gonna follow up with you and be here for you. So typically, hopefully, it lasts forever. That's what I hope for all my patients. If it's a partial tendon issue, partial tendon tear, that kind of thing, we're hoping that those things get better and we never have to see you again. Now, if it's a chronic degenerative issue and we talk to our patients, we work with our patients, we make sure we get our patients in for follow-ups, and we work with them to make sure that they're hopefully don't have to be repeated, but if they do, we're here for you. Is there an issue with patients on anticoagulants? Absolutely. We work with the patient to make sure, just like any type of procedure, if you're on Eliquis or some sort of anticoagulants, we will work with you to make sure that we get you to do this responsibly and that you have the best outcomes possible. So yes, if there are anticoagulants involved, we will discuss those and make changes appropriately and work with your cardiologist, neurologist, or primary care doctor to make sure we make the right changes. Recovery time, 48 to 72 hours of inflammation and swelling typically. And then after that time frame, you'll be back about to your baseline about 3 to 5 days. And then slowly you'll start getting better and better and better. Thanks, Grace. Thank you. What are impacts to the knee in dealing with a hip that's bone on bone until it's replaced? Michael, this sounds like a very focused issue here. Depends on what we can do for the hip. If we can do anything to help the hip in the interim and make it a little bit better, we're always going to try to strengthen the hip, even if it's going to be replaced. So might be able to do some PT, some things to help you there. So go with that. That's gonna be the recommendation of the clinician. They're going to talk to you about good, better, best. That's how I make it out there. Might have a great result with PRP, might be less long lasting sometimes in some terms of some degenerative conditions. And that's what I would say. Some platelet-rich plasma sometimes doesn't have as long-lasting results. The bone marrow might give you longer-lasting results and never have to have the procedure again. So I'll talk to you about good, better, and best options during my evaluation if you want to see me or you want to see one of my colleagues. All right, guys, I have to get back to patient care. I hope this was informative. Hope you learned some things. If you have any other questions, please feel free to jump on the website, go check out some of our blogs, or you can call us to schedule an evaluation. It's an hour long. You can ask all these questions there. We do telehealth and telemedicine evals as well. So thanks everybody for their time. Everybody have a wonderful, happy Thursday.